Assalamu alaikum. Let's discuss about renal vein thrombosis. In renal vein thrombosis, the cause is hypercoagulability or it may be due to trauma. So hypercoagulability and may be due to trauma. In hypercoagulability, there will be nephrotic syndrome. We know that in nephrotic syndrome, 3 plus protein without hypertension, massive proteinuria, edema, particularly membranous nephropathy. It may be due to malignancy, especially renal cell carcinoma. Other cause like inherited thrombophilia and may be due to OCP. And it happens due to trauma also. So hypercoagulability and trauma. If we look at the clinical features, there may be acute symptoms, there may be chronic feature. In acute case, there are renal infarction syndrome symptoms. Renal infarction. What we will found in renal infarction? In renal infarction, there may be flank pain, there may be hematuria, flank pain, hematuria, and there may be increased LDH, flank pain, hematuria, increased LDH, and increase kidney size on imaging and increase kidney size in imaging. So this is very important. There is increased kidney size on imaging. In chronic cases, there may be renal symptom usually absent and may cause pulmonary embolus. In chronic renal vein thrombosis, there may be pulmonary embolus. Diagnosis is CT scan, CT or MR angiography, and renal venography can be done. CT or MR angiography and renal venography can be done. And as a treatment, we can use anticoagulation, local thrombolysis, or thrombectomy should be done if AKI is present. Now, look at this question. This 50-year-old woman comes to you. Why? Due to increasing right flank pain, nausea, and hematuria. The flank pain started 3 days ago and is constant, dull, and non radiating. She reports no dysuria. The patient was diagnosed with pancreatic cancer. So, one risk factor found malignancy, pancreatic cancer a month ago and received the first cycle of the chemotherapy. She has smoked a pack of cigarette daily for 30 years. Okay, does not use alcohol, temperature normal, BP normal, pulse normal, respiration normal. Examination show right flank and costovertebral angle tenderness. Bowel sounds are present, peripheral pulses are normal, there is no edema. On lab, their hemoglobin is 13. Platelet, okay, everything fine, fine. Look at the RBC. RBC is 20 to 30 high power filled. Okay, important in here, there is abdominal ultrasound. Abdominal ultrasound shows enlarged right kidney but normal left kidney. Enlarged right kidney but normal left kidney. There is no evidence of hydronephrosis. Nephrolithiasis can cause enlarged kidney, but there should be hydronephrosis. But in here, no hydronephrosis, but enlarged kidney and the normal left kidney. The pancreatic mass is unchanged from prior scan. So pancreatic mass hasn't changed. What is the reason? What is the cause? Malignancy, presence of Renal infarction syndrome, there is hematuria. Renal infarction syndrome like hematuria, LDH is not done here, but increased kidney size on imaging, but no signs of hydronephrosis. These are the very high yield point. So looks like RVT, renal vein thrombosis. Okay, this patient who has acute renal vein thrombosis in markedly increased glomerular pressure, leading to renovascular congestion, capsular stretch, manifesting as flank pain and hematuria. RVT most commonly occur in the setting of nephrotic syndrome. In the setting of nephrotic syndrome, but look, RVC actually present not in nephrotic, usually present in nephritic, but in here it is present, usually present in nephrotic syndrome. RVT most commonly occur in the setting of nephrotic syndrome due to urinary loss of anticoagulant protein and alteration of the hemostatic balance, but can occur with acquired hypercoagulability associated with malignancy, as in this patient. Lab analysis typically demonstrates there is hematuria elevated LDH level, possibly related to necrosis in the setting of thrombosis. AKI may occur, but is more typical in the setting of bilateral RVT. So AKI can happen, but it usually happens if there is bilateral RVTs. Renal ultrasound with Doppler and abdominal CT scan can have low sensitivity manifestation, may demonstrate only an enlarged kidney, but although a Doppler ultrasound may show a reversal of diastolic flow. The diagnosis is confirmed by CT or MR angiography or renal venography. Management actually depends presence of AKI, on the presence of AKI, which, if present, require urgent clot removal, doing thrombolysis or thrombectomy. Otherwise, anticoagulation alone is appropriate. Okay, look at this option. Nephrolithiasis can cause flank pain, hematuria. However, it would not explain the enlarged right kidney without hydronephrosis. And the pain of nephrolithiasis is often paroxysmal rather than dull and constant pain. And there is a significant overlap in the presentation of renal infarction and acute RVT. However, renal infarction most commonly occurs due to cardiometabolic disease, atrial fibrillation, resulting in incomplete infarction and a wedge-shaped area of ischemia of on imaging. In addition, patients frequently report abdominal pain in addition to flank pain, and in acute increase in blood pressure due to renin release is common. Okay, for renal infarction, this is very common, like acute increase in blood pressure due to renin release. Okay, look at this question. A 31-year-old previously healthy woman is evaluated for 6 weeks history of periorbital edema and abdominal distension, blood pressure normal, pulse 80, physical examination show moderate ascites, lower extremity edema, urine show proteinuria and 24-hour urinary protein excretion is 4 gram per day. Looks like nephrotic syndrome. Total serum protein is 5, albumin is low, hypoalbuminemia. Patient for advised to follow a low sodium diet and oral diuretic is prescribed. Kidney biopsy is scheduled several days before the procedure. The patient experienced sudden onset right flank pain, gross hematuria, sudden onset right flank pain, gross hematuria. Which of the following is the most likely diagnosis? It may be renal vein thrombosis. Okay, it is renal vein thrombosis. The risk of other thromboembolic event like DVT, pulmonary embolism is increased risk in nephrotic syndrome. The risk of renal vein thrombosis and other thromboembolic event, DVT, pulmonary embolism is increased in nephrotic syndrome due to hypercoagulability caused by urinary loss of anticoagulant protein antithrombin 3. The renal veins predisposition to the thrombosis and may be due to hemoconcentration, higher viscosity of postglomerular circulation that results from glomerular fluid loss. Although RVT is more common, although renal vein thrombosis is more often chronic and asymptomatic. Acute renal vein thrombosis typically causes findings of renovascular congestion, flank pain, increased glomerular pressure, hematuria, and or renal infarction, increased LDH. Acute kidney injury may result when renal vein thrombosis is again bilateral. So patients with nephrotic syndrome require a high index suspicion for RVT, that is typical presenting symptom like flank pain and hematuria. So patients with nephrotic syndrome requires a high index suspicion of RVT, that is typical presenting symptoms of flank pain, hematuria overlap with other common disorder like nephrolithiasis. Renal vein thrombosis risk and that of the other thromboembolic events is increased by all cases of the nephrotic syndrome, but appears highest with membranous nephropathy, we have already discussed. And we know how to diagnose. Okay, so that's all about renal vein thrombosis. Hope you enjoyed.